Bismillahirrahmanirrahim. Assalamu alaikum. My name is Dr. Murtaza Ali Goa and I'm working as an associate professor at Pediatric Electrical Care Unit at NICH. So today I'll be talking about the fluid therapy in hospitalized children. So I don't have any disclosures. So as you all know that in every pediatric department, fluid therapy is encountered, and there are so many problems if you don't have the knowledge about the fluid therapy. And one must know about the kinetics and the molecules dissolved in it. There are so many things which occurs usually in the pediatric department as in terms of fluid therapy. So today I'll be discussing about all these things in the light of the current evidences. So in a nutshell, I'll be talking about this when, what and how of fluids in hospitalized children, and why the fluid needs, what are the indications, what are the phases of fluid therapy, which fluid, either isotonic or hypotonic, how to assess fluid needs and restricted versus normal infusion rate, how to remove extra fluid overload and de-escalation, and some special situation, and what about the new update. So this is the most common medical intervention which usually occurs at the pediatric department. It can be given to those who can't be fed orally, provide free water and electrolyte in a fasting child, supportive care for a variety of diseases, and with increased advances it has become more complex and it is not as innocuous as once thought to be. And the reality is we do it rather badly. We delegate it to probably the most junior member of our medical team, and it is probably the least understood of all the tasks that they do. If you look at the history of the fluids, that when it was started, it was in 17th century when there was some cholera epidemic in London, and the list of drugs were applied at that time in the terms of mercury, opium, brandy, mustard, and even rubra. Then the breakthrough came when Thomas Letta described his first attempt to replace the lost fluids and salts by salt solution. So at that time the first normal saline was invented. Let us look at the time frame of our understanding. That in 2001 there was a famous study by Rivers et al. That was published in New England Journal of Medicine, and that was early goal-directed study, and they emphasized on fluids to achieve targets, and practice was more towards fluid boluses. So that was the era in which they were focused on resuscitation, just to give the fluid. And then after 2003 to 2010, we saw a lot of papers had been published specifically towards the maintenance fluid, and that was creating hospital-acquired hyponatremia. So there were so many evidences against hypotonic fluids as a maintenance fluid. So initially we saw there was a resuscitation was done initially, and then in the same simultaneously the people started to look for the maintenance fluid. Like in our residency program, we used to use this 0.45% dextrose saline, which was hypotonic. And in the last decade, in 2010 to 2020, when the people were giving the isotonic fluid, so they noticed that the problems occurring with the fluid overload, hyperchloremic metabolic acidosis, and evidences against isotonic fluid. Isotonic fluid, your normal saline is an isotonic unbalanced crystalloid. I'll talking about the balanced and unbalanced crystalloid, but remember normal saline is an isotonic fluid, but it's a kind of unbalanced crystalloid. So here we saw that our understanding has changed with the time period, that initially we were focused on the resuscitation, we were forced to give the boluses, and then by using this hypotonic fluid we saw a lot of hospital acquired hyponatremia. And then in the last decade, when the people started to give the isotonic fluid, that also causes the problem with fluid overload, hyperchloremic metabolic acidosis, and that is because of your unbalanced crystalloid. Why fluid indications? As you all know, there are three indications: resuscitation, replacement, or maintenance. So in terms of resuscitation, to maintain normalize the hemodynamics, to return the ICF to normal, and in terms of replacement, replace ongoing gut or renal losses, and in terms of maintenance, that they provide glucose to the brain and maintenance to match insensible losses. Now, it's very important to give the fluid, and the fluid needs are dynamic. They keep changing as the patient during the course of the hospital stay. They keep changing as the disease evolves. So the concept of rows arise, that R for resuscitation, O for organ support, S for stabilization, and E for evacuation. So fluid requirements vary according to the phases of illness. So I'll be talking about these steps in my presentation in the light of the current evidences. Starting with the first phase of resuscitation, like the main aim is to correction of the shock with the achievement of adequate perfusion. So here हम जो बात कर रहे हैं कि जो फ्लूइड थेरेपी के फेजेस हैं कि जो स्टार्ट होता है रिससिटेशन में, हमारा कंसेप्ट जो पहले रिससिटेशन की तरफ था, फिर वहाँ प्रॉब्लम्स आए, देन मेंटेनेंस में हमें हाइपोटोनिक हॉस्पिटल एक्वायर्ड हाइपोनेट्रीमिया हुआ, इसके बाद लोगों ने आइसोटोनिक फ्लूइड यूज़ किया, उसमें प्रॉब्लम्स आ रहे थे. नाउ वी आर सीइंग दैट कि आफ्टर एडमिशन कौन से फेजेस से जो है आपके बच्चे गुजर रहे हैं जो आपको फ्लूइड देने पड़ रहे हैं. इसमें रिससिटेशन है, करेक्शन ऑफ शॉक करना विद अचीवमेंट ऑफ एडुकेट परफ्यूजन. Now here you can see that this is the first hit. Suppose the patient is having the septic shock because of the sepsis. So this is the ebb phase, and the questions need to ask with the physician that when to start the fluid and what are the benefits of fluid. The physician जो उस वक्त attending physician है वो देखेगा मुझे fluids क्यों start करना है और क्या benefit है. But in this phase of resuscitation, the fluid in this phase is mandatory. Type of fluid, always crystalloid. Either the balanced crystalloid or unbalanced crystalloid. Remember, normal saline is an unbalanced crystalloid. And the rate should be in the bolus form. Our target is to achieve micro and macro circulation. Micro means the tissue perfusion, and macro circulation means your vitals, heart rate, blood pressures, urine output, CVP. And the time frame should be within the minutes. Now it's very important to look for the triggers for the fluid. So I have divided into two phases, the pre-feast trial and the post-feast trial. Feast trial I'll discuss, that was a very famous study which was conducted in 2011, and that has changed our concepts of fluids panacea. I'll be talking about later. So in the pre-feast trial, there was survey conducted in 391 ICU in 2007, and the common trigger was impaired tissue perfusion with low major cardiac output. So 44% of fluid resuscitations जो दिया गया इस वक्त वो सिर्फ impaired tissue perfusion पे दिया गया, low cardiac output पे दिया गया. And importantly, if you look at this, 35% of this resuscitation were given only on abnormal vital signs, जिनके सिर्फ blood pressure, heart rate और numbers को देखा गया और उनको जो resuscitation किया गया. And the same survey was conducted in 2014 after the feast trial, post-feast trial, the people were become more conservative. अब यहाँ पे 61% of जो resuscitations जो दी गई हैं, that is because of impaired tissue perfusion और low major cardiac output, while 25% जो है वो resuscitations just दी गई हैं because of the abnormal vital signs. Now feast trial was conducted in sub-African countries, and they noticed that the administration of boluses of 0.9% saline and 5% albumin significantly increased 48 hours of mortality. उन्होंने ये नोटिस किया कि जो बोलसेस दिए गए बच्चों को उसमें सेलाइन या एल्बुमिन के उनकी मोर्टेलिटी ज़्यादा है रादर देन उनके जिनको बोलसेस नहीं दिए गए. Now the reasons are because they have got the comorbid conditions, because the developing countries like us के malnutrition भी common है, anemia भी है, infections भी हैं, तो ये बच्चे जो हैं बोलसेस को नहीं बर्दाश्त कर सके जिसकी वजह से इनकी मोर्टेलिटी बढ़ी. Therefore the clinical practice has moved away from fluid boluses to treat abnormal vital signs in patients without impaired tissue perfusion. Now अब जो clinical practice है, initially that was कि tachycardia, heart rate बढ़ा हुआ है, आपने boluses दिए just to see the numbers, but that will not tell you the actual picture of your tissue perfusion. Maybe you have to look for the lactate or something like that just to look for the tissue perfusion, but just to correct the vitals, that should not be the target. So the clinical practice has moved away from these fluid boluses to treat abnormal vital signs in patients without impaired tissue perfusion. Again, there was another study which was published in 2019. They reanalyzed the FEAST trial because the people, they couldn't believe that the fluid boluses could have caused so much harm. उन्होंने बहुत सारे लोगों ने इस पर एतराज़ किया. उन्होंने कहा कि फीस ट्रायल जो है उसको रीएनालाइज करते हैं बिकॉज उनको भरोसा नहीं आ रहा था कि फ्लूइड बोलिसिस जो हैं क्या वो वाकई नुकसान करते हैं. व्हाट डिड दे फाइंड आफ्टर दैट कि एल्बुमिन एंड सलाइन बोलिसिस कैन कॉज respiratory and neurological dysfunction, hyperchloremic metabolic acidosis and reduction in hemoglobin concentration as well. जब रीएनालाइज किया फीस ट्रायल को तो उन्होंने देखा कि इसमें सिर्फ ये प्रॉब्लम नहीं, इसमें दूसरे आपके दूसरे सिस्टम्स भी इन्वॉल्व है. रेस्पिरेटरी भी प्रॉब्लम में आ जाता है, न्यूरोलॉजिकल भी प्रॉब्लम में है, एसिडोसिस भी हो रहा है, हीमोग्लोबिन कंसंट्रेशन पे भी प्रॉब्लम है. So finally they said that fluid resuscitation, the second thing is fluid resuscitation with unbuffered electrolyte solution may cause harm. It's for the boluses. And the second thing is that कि जो fluid resuscitation के type of fluid choose किया गया unbalanced crystalloid वो further harm कर रहा है इसे. So the first thing is what is balanced buffer crystalloid, that which has the minimal effect on acid base balance and lower chloride content. It's very important कि जो भी fluid type of the fluid आप use कर रहे हैं उसका chloride content कम हो, minimal effect on the acid base balance हो. And the second bone of contention is that type of the fluid. Balanced crystalloid or unbalanced crystalloid. Now the normal saline is an unbalanced crystalloid that causes hyperchloremic non-ion gap metabolic acidosis, afferent arterial constriction, reduced renal perfusion in AKI, and how it occurs that you can see in this diagram that how this unbuffered crystalloid which has a high chloride content that causes a lot of problem. Like here you can see that if you give the fluid which has more chloride, that the proximal tubular absorption of the chloride and renal tubular absorption, again that causes entry of chloride into the macula densa, and there is depolarization of the basement membrane and release of adenosine. Now this adenosine causes vasoconstriction and increased afferent arterial resistance and decreased renal perfusion, and finally the GFR would be decreased and you have the decreased urine and sodium output. So that normal saline which is unbalanced crystalloid that causes hyperchloremic metabolic acidosis. Now we look at the surviving sepsis campaign, that what are their recommendations and highlights. In the fluid resuscitation, what they said that if ICU available, if you have the ICU, we suggest administration of up to 40 to 60 ml per kg of bolus, and that is your weak recommendation and low quality evidence. Whereas the ICU is not available and there is no hypotension, so we recommend against bolus fluid administration. So there is a strong recommendation. So these are the recommendations for the boluses, number one. Number two, now which solution will you need to choose it? Like we suggest using crystalloid rather than albumin, number one. And number two, the balanced buffer crystalloid rather than 0.9% saline. So you need to give the balanced crystalloid rather than the normal saline. So there are so many evidences, and there was one study which was conducted and that shows the chloride liberal fluid, which is normal saline, gelatin, albumin, to chloride restrictive fluid. And what did they find? The chloride restrictive regime nearly half the risk of AKI in RRT. जिनमें chloride कम था उनकी जो है AKI acute kidney injury और renal replacement therapy की ज़रूरत उनको नहीं पड़ी. Now, if you look at the key points of the resuscitation phase, the first phase, the triggers must be specific. Tissue hypoperfusion is the key. Like maybe after giving the fluid, you need to look for the lactate and to see that how the tissue perfused. And isotonic fluid always. Isotonic, you don't need to use the hypotonic fluid, isotonic fluid, but yes, the debate would be there. Either this is the balanced buffered or unbalanced buffered. Remember microcirculation and macrocirculation discordance. I mean, there's a difference. You cannot predict that by correcting the numbers of vitals, you will achieve the tissue perfusion as well. And rate of administration depends on clinical parameters, comorbidities like anemia, malnutrition, respiratory worsening should be anticipated, and balanced fluid coming up, final word awaited. Cost is of major concern. So now first we have completed our resuscitation phase. The child has passed through the resuscitation phase. Now the phase optimization phase comes in. Now first we have given the fluid. The flow is established. The cause is ischemic reperfusion. The question is when to stop fluid. What are the risks of the fluid? Now the physician, once they ask when to start the fluid, now here the questions are exactly opposite, that when to stop the fluid and what are the risks of the fluid. Fluid in this phase is assess fluid responsiveness based on individual needs. Target should be organ perfusion. Now you need to optimize. The child is going towards the second phase of the fluid therapy. Now what has happened to that fluid what we have given in terms of bolus? Now studies have shown that suppose in sepsis less than 5% of crystalloid remains intravascular at the end of the 1 hour. If you see this graph, you can see starting the 0 minute and then at the 5 minutes there will be expansion of the intravascular volume, and at the end of the 60 minutes again your stroke volume and mean arterial pressure return to the baseline at 1 hour. So where does the fluid go? Fluid seeps into the interstitial compartment and that causes the tissue edema. So that means कि जो आपने बोलस दिया था वो within an hour जो आपने इंट्रावेस्कुलर रिस्टोर करने की कोशिश की थी वो within an hour वो वापस से बेसलाइन पे आ जाता है और जो फ्लूइड होता है वो आपका इंटरस्टिशियल कंपार्टमेंट में जाके that causes the tissue edema. So truth lies somewhere in the middle. If you don't give the fluid, what will happen? There would be hypovolemia, reduced tissue perfusion, anastomosis, leakage, and confusion and risk of CVA, splenic ischemia, renal failure. And if you give more fluid, there are chances of getting this hypervolemia, edema, intra-abdominal hypertension, respiratory failure, and so many things. Now here we just look at the little bit of physiology will help us, like in terms of Frank-Starling curve. Here you can see the red arrow that the graph is peaking over here, and you see over here the graph is peaking, and at this point if you give fluid there will be increase in the cardiac output. But when the graph is flattening over here at point B, if you give the fluid there will be no increase in the ventricular pressure, so just increase in the accumulation of large increase in the lung volume water. So here at point A, if you give the fluid, the patient will be responsive, but if you give the fluid at the point B, you will not get any kind of advantage of giving the fluid unless you will you will just give the more fluid and the fluid will accumulate in the lungs. So how to assess fluid needs in the sick children? There should be static and dynamic parameters, and in static parameters because that will not give you the actual picture like CVP and right ventricular end diastolic volume and left ventricular end diastolic volume. So they are the poor predictor. They do not reflect the patient status on Frank-Starling curve. They will be affected by the ventilation, interthoracic pressure, and inter-observer variability. So here we need some dynamic parameters that will tell you the exact picture of the patient. So here we use usually the IVC collapsibility. Those who does the intensive care unit, they know that how to calculate the IVC. So there are collapsibility index and distensibility index, and by that means you can assess that how much patient needs the fluid. So this optimization phase, first we have covered the resuscitative phase. Now this optimization phase, what we need to do, we need to maintain the volume, and as far as we need to look for the predictor of fluid responsiveness, that at one point you need to see that if you give the fluid whether the patient is responsive or not. And the second thing is that over here the early use of vasopressor. Now again we need to look for that either without filling the tank, if you start giving the vasopressors, what will happen, that will be tissue ischemia, and you will get more, the patient will be more getting more harmful if you start vasopressors without filling the tank. So you should be very cautious when you start the vasopressors. Now come to the third phase of stabilization. After crossing the resuscitative phase, optimization phase, now come to the stabilization phase. That phase provides water electrolytes to replace ongoing losses and provide organ support. So this is again the second hit, and here there is ischemic reperfusion, and now the question needs to ask by the physician that when to stop the fluid and what are the risks of the fluid. So that again here you need to be very cautious about the type of the fluid, target and time frame. So this is a very well-known study. We all have grown up with this Holliday-Segar, which was published in 1957 for this maintenance need for the water and parenteral fluid therapy. All of you are aware of this fluid requirement for first 10 kg, next 10 kg, more than 20 kg, and electrolyte requirements. However, there has been a lot of criticism occur on this Holliday and Segar because the calculation based on the finding of healthy children, and it can't be for acutely sick children due to different physiology, because Holliday और Segar ने जो अपनी स्टडीज प्रूव की थी वो हेल्दी चिल्ड्रन में थी, बट जब बच्चे सिक होते हैं, बीमार होते हैं, तो उनकी फिजियोलॉजी डिफरेंट हो जाती है, उनकी जो रिक्वायरमेंट है वो कम हो जाती है, तो उस हिसाब से उस वेट के ऊपर आप जितनी भी कैलोरीज देंगे तो और नुकसान होगा. एन एस्टिमेटेड एनर्जी एक्सपेंडिचर बेस्ड ऑन बॉडी वेट इज अनरिलायबल, impaired excretion of free water and generation of EF, extra free water by the kidneys. So here you can see in this small ball there is an SIADH free water retention. The patient is in, suppose in the ICU में patient admit है, SIADH हो रहा है, free water already वो retain कर रहा है because of the disturbances in the body physiology. Now इसकी requirement is a less caloric expenditure, but you are giving the overestimation of intake by applying this Holliday and Segar. Now what will the kidneys do? They will start diuresing the solute. वो मज़ीद diurese करेगी, solute को निकालने की कोशिश करेगी, and that you have hypotonia over there. And above and all, अगर आप इसमें hypotonic fluid देते हैं साथ में, तो this is a sure short recipe for hospital acquired hyponatremia. So you see there are so many factors which causes this hospital acquired hyponatremia. And then later on so many papers were published about this hypotonic fluid. Hypotonic fluid, remember I am talking about this half strength 0.45% dextrose saline, your ringal lactate, these are hypotonic fluid. So hypotonic fluid has a higher incidence of in hospital acquired hyponatremia in acutely ill children. So people started to give the isotonic solution, which is the best prophylaxis against hospital acquired hyponatremia. Now again remember isotonic fluid. This is isotonic, and the kind of fluid is either the balanced crystalloid or unbalanced crystalloid. Again I will repeat that normal saline is an unbalanced crystalloid. Now after this first resuscitation, optimization and stabilization, now we come to the evacuation phase that removes excessive fluid by spontaneous or induced or renal replacement therapy. So this is the third head. Now it has been beautifully described by the describer that global increased permeability syndrome. So now once you have given the fluid, you maintain the fluid goes on and sets into the tissue. Now we need to start unloading the fluid. And what are the benefits of fluid removal? So we again based on individual needs, and our target is to keep the negative fluid balance. Now these are the pulse of the fluids in critically ill children. Now hyponatremia occur, hyperchloremia occur. The two most important parameters are the fluid overload and worsening organ dysfunction. Risk factor for fluid overload. Now how the fluid will overload? You can see over here sepsis में altered capillary permeability होती है जिसकी वजह से fluid जा रहा है. Again body disturbances हो रही है, SIADH phenomena आपका activate हो रहा है, आपने resuscitation fluid भी अलग से दिया हुआ है. And the fourth is your fluid creep. Fluid creep is very important, and I'll discuss later in my slide. A little bit of physiology over again. This is the Starling principle. This is different from the Frank Starling curve. If you see on the left side, there's a classic Starling principle in which there's a fluid leaves the vessels at the arterial end of capillary bed because of hydrostatic pressure exceeds oncotic pressure. Again, this is the classic Starling principle. And fluid re-enters the vessels from interstitium at venous end because of hydrostatic pressure lowers the oncotic pressure. This is the normal classic Starling principle. Now what happened once your endothelium is injured, your glycocalyx is injured? What happened that you can see the fluid from interstitial space enters vasculature through the large pores. Your glycocalyx is the main determinant. Once it is injured, you will get the fluid in the interstitium. So that will also cause the interstitial edema. Now come to the concept of the fluid creep. What is fluid creep? Fluid creep is basically the sum of the volume used for पेटेंसी ऑफ आईवी फ्लूइड, जो आप नॉर्मल मेंटेनेंस अपनी लाइन मेंटेन करने के लिए फ्लूइड स्टार्ट करते हैं. व्हीकल्स फॉर ड्रग, जो डाइल्यूशंस होती हैं ड्रग्स के अंदर हम यूज करते हैं. एंड समटाइम्स कंसिडर्ड इलेक्ट्रोलाइट्स एडेड टू फ्लूइड फॉर गिवन सेपरेटली इन टर्म्स ऑफ योर राइडर. सो दीज आर द थिंग्स जो हम ये फ्लूइड अलग से दे रहे होते हैं, दैट इज कॉल्ड द फ्लूइड क्रेप. Because we usually concentrate on your resuscitation and the maintenance fluid and the replacement fluid, but somewhere we forget about this fluid creep, which in terms of your IV, patency and all these electrolytes. So interestingly, there was a survey conducted in Belgium in 2007 to 2016. There was a retrospective study, and what did they find? The interesting findings are resuscitation fluid comprised of 6.5%. And maintenance replacement with added electrolytes 24.7% of daily intake. But if you look at the fluid creep, they are accounted for 32.6%. So that is a major chunk which we are giving, but we just that's hidden from our eyes. So here you can see the fluid dynamics over time in the PICU. From day 1 to day 5, here you can see the different colors. The orange one is your resuscitation, red is your blood product, blue is for maintenance fluid, gray is for your nutrition, and yellow is for fluid creep. So as you can see that the blue one is main dominating, and then from day 1 to day 5 you can see the pie chart over here that the fluid creep has accounted more and similar from day 1 to day 5. So after that, a lot of evidences has come in that if you give them more fluid, there will be fluid overload, interstitial edema, organ dysfunction, and mortality associated with the increased cumulative balance. So there are so many studies which published on this. An association between fluid overload and mortality. If you give fluid, that will definitely impact on your renal, hepatic, GI, cardiovascular, respiratory, central nervous system, and abdominal walls. So all of your system are affected by giving the fluid overload. Now after this resuscitation, optimization, stabilization, and evacuation, now we need to do as a targeted de-resuscitation. If we have given the fluid and the fluid goes on, now we need our duties to remove these fluids. So active fluid removal using diuretics or ultrafiltration, here we need to act like a nephrologist. Diuretics recruits, the another advantage of giving the diuretics recruits a microcirculation, decreasing diffusion distance. And it has certain steps. It's not like that you just start giving the diuretics without having certain goals. So you have to have certain steps that you have to follow. You must have some target that what you want to achieve by giving the diuretics or by giving the de-resuscitation. That is improvement of the oxygen, set a fluid goal, set perfusion and renal safety precautions, re-evaluation after 24 hours unless safety limited reach, and adjust the plan accordingly. So now what do we need to do? If you give the fluid, that will be more harmful. If you don't give the fluid, you are in trouble. So because fluid therapy in critical illness is a tightrope walk. So if by giving inadequate fluid, worsening tissue hypoperfusion and hypoxemia, overhydration causes worsening tissue edema and organ dysfunction. So what do we need to do? We need to follow this fluid stewardship, like antibiotic stewardship, because it's a drug. You need to have certain indication in which you need to write the fluid. You have to have a proper dose and a proper rate, and the duration should be mentioned, and you should de-escalate it, that graded removal, to prevent fluid overload. So we need to make some fluid stewardship like an antibiotic, and we need to follow these steps. So is there any ideal fluid which fits for all, that we can give one fluid to any situation that will fit and that will be more advantage for that? So there is no as such ideal fluid. You need to have certain indication and a scenario and need to adapt it accordingly. So now what are the indications for isotonic fluid? In which conditions I have to give the isotonic fluid? Yes, where you need the higher effective osmolarity needs to maintain, like in sepsis, septic shock. There is an hypovolemic state, and sometimes you volemic state with AVP excess, and post-operative setting. So these are the indications for the isotonic fluid. Where you need to restrict the fluid, there are 2 or 3 indications. In edematous states like congestive heart failure, nephrosis, hypoalbuminemia, and oligouric state like acute glomerulonephritis, acute tubular necrosis, and end-stage renal disease. So these are the 2 or 3 indications in which you need to restrict the fluid. Now, hypotonic fluid, as I mentioned, that don't use the hypotonic fluid, but that does not mean that they have been thrown away completely. Yes, there are some conditions in which you need the free water deficit, like hyponatremia, renal concentrating defects like congenital nephrogenic diabetes insipidus, and some other diseases, and extra renal free water losses, where you need some hypotonic fluid as well. So if you look at the disease-specific fluid prescriptions, so first you have this indication for the isotonic fluid, where you need to restrict the fluid. You can give hypotonic fluid in some conditions, and disease-specific fluid prescriptions, like if you have the patient with the CNS illnesses like meningitis, encephalitis, and whatever else, you can start with 100% of the fluid and titrate according to the input-output and sodium status. Fluid restriction is if clear evidence of SIADH. So it's clear that in the CNS you need to give the 100% fluid. Only in SIADH condition where you need to restrict it. Now in the respiratory illnesses, start with 80% of the maintenance in pneumonia, asthma, and bronchiolitis. Congestive heart failure and myocarditis, you can start with the 50 to 60% of maintenance fluid to begin with. May require more fluid if associated with the sepsis and diarrheal illness. And nephrotic syndrome depends on case-to-case basis, may start with 80% of the maintenance fluid. Now in the tumor lysis syndrome, rhabdomyolysis, and certain drugs like acyclovir, where you need to give hyperhydration. Here you need to give 1.5 times maintenance fluid. That is more important. Now what are the challenges clinicians face these days? Now, as I have told you before, that 0.9% normal saline is an unbalanced crystalloid. It's an isotonic fluid, but it's an unbalanced crystalloid. So, how physiological is normal saline? Is this normal? Is this physiological? A big no. Because the osmolarity is physiological, like you can see over a 308 over 291. Our plasma is 291. And normal saline contains 308 osmolarity, but the concentration of sodium and chloride is not. Here you can see in the normal saline the sodium is 154 and the chloride is 154, but here in our plasma we have sodium of 142 with potassium, calcium, magnesium, chloride, bicarb, lactate. So this is a normal plasma constituents and composition, and this is a normal saline. So normal saline is not normal. There are certain papers published on that causes hyperchloremic metabolic acidosis. As I have already mentioned in my previous slides, that how this hyperchloremic metabolic acidosis occur because of normal saline. So we challenge the first challenge with normal saline that causes hyperchloremic metabolic acidosis. Number 2, the ringer lactate, the second solution which is available, which is cheap, but again the problem with the ringer lactate is that is hypotonic. The sodium is 130 and which contains 27 of lactate. So again the problem with this ringer lactate is hypotonic and you have more lactate. Now exogenous lactate, if you give the lactate, that which converts into bicarbonate. So lactate requires 3 moles of oxygen to generate 1 mole of bicarbonate. So it is and the second thing is that also causes the hyperglycemia. So the challenge with the lactate is that is hypotonic fluid and it requires more oxygen. Number 3, that causes hyperglycemia. So it makes no sense to further increase oxygen consumption in a patient with a pre-existing tissue hypoxemia. Or patient is hypoxic already, patient is in distress, patient is in sepsis, and if you think that by giving the ringer lactate, the lactate will help you, but lactate requires more oxygen, at least 3 moles of oxygen to convert it into bicarbonate. So it is useless to give the lactate in already pre-existing tissue hypoxemic patients. So the challenge with the ringer lactate, again hypotonic. So now heading towards the perfect balance, new isotonic balanced electrolyte solution, which is now what is balanced solution? Balanced solution is one having physiologic concentration of electrolytes, sodium, potassium, chloride, calcium, and magnesium, and should have a base like bicarbonate or metabolic anion like acetate, lactate, malate, or gluconate. So here is a new balanced crystallite solution, the name of stereofundin. What is that? Stereofundin is a fully plasma adapted and isotonic balanced electrolyte solution, and the osmolarity is 290 milliosmol per kg. So the problem stereofundin. अब जो स्टीरोफंडिन है वो प्लाज्मा से रिलेटेड है, हमारे बहुत ज़्यादा बिल्कुल एक्यूरेट नहीं है, बट इसकी कंपोजिशन सिमिलर है ऑलमोस्ट प्लाज्मा के साथ. एंड द न्यू फ्लूइड विच इज़ बीइंग यूज्ड इन द यूरोपियन और वेस्टर्न कंट्रीज विच इज़ द Plasma-Lyte, which has the actual composition of our plasma. But here we have the stereofundin which is available, so we can use this stereofundin. It is lactate free, so it can be given to the diabetic patient. Lactate metabolized in the liver, but stereofundin metabolized in the tissue, so it is very effective for the liver compromised patients as well. Now acetate plays a central role in carbohydrate and lipid metabolism, metabolized significantly faster than lactate, metabolized unaffected in diabetic, and turnover unaffected by age, and it provides energy of 209 kilocalories per mole. So here are some publications for acetate is a balanced solution. Now here you can see that the lactate is converted into bicarbonate via the liver. So it is very harmful if the patient is having some liver disease. If you give the lactate, that will not convert into the bicarbonate. But the acetate, here you can see the acetate and malate that converted into bicarbonate via the muscle. Now here you can see the advantages of acetate over lactate. The acetate, that the bicarbonate production just in 15 minutes, whereas the the bicarbonate production will be delayed. In acetate, you don't need the oxygen consumption, whereas in lactate, you need more oxygen, at least 3 moles of oxygen to convert into 1 bicarbonate. And in metabolic organs, like in case of shock or in patients, you just give the acetate. But in case of shock, you will not assist the lactate, because in shock, you will have some false reading for the lactate. Gluconeogenesis, like in acetate, no hyperglycemia via gluconeogenesis in the liver, whereas in lactate, there will be hyperglycemia. And you can use as lactate as a hypoxic marker in acetate, but not in case of lactate. So here you can see the composition of different fluids, that plasma composition and stereofundin is almost similar, but here you can see the chloride content in plasma is 103, but here in stereofundin it is 127 as well. But in normal saline, the chloride is 154. But in the Ringer's lactate, it's 112, but again, the sodium is 131. The problem with the Ringer lactate is hypotonic, and that causes more problems. Now look at the evaluation of IV fluid, IV solutions when it was started. It was started in 1850. The saline was first invented in 1850, and then in 1890 there was a Ringer's, and in 1950 there was a Ringer's lactate came in, and stereofundin came in 2007. So stereofundin is a balanced salt solution, acetate as a buffer, not as a lactate. It's still cheaper than colloid, marginally more expensive than the Ringer's lactate, freely available, and appears to have a better profile with strong ion defense and base access. There are some recommendations even you can use in the dengue, even after surgeries. There are some studies in traumatic patients where the balanced solution is far better. So the maintenance of intravenous fluid for children, enough evidence is now for translation and action. So the key points are, we need to follow the 4 Ds of fluid therapy, like fluid stewardship, isotonic fluid always for volume resuscitation, but require more answer on balanced fluid, that you need to give the crystalloid, isotonic crystalloid solution, but that should be balanced, not unbalanced. Balanced solution, like stereofundin, a little bit balanced, rather than 0.9% normal saline, it's an unbalanced crystalloid. Hypotonic fluids no longer recommended for maintenance due to risk of hyponatremia. Post-resuscitative conservative fluid strategy to minimize fluid overload, and early fluid removal key to salvage organ system. So thank you very much from my side. The key messages you need to think that by giving the fluids, because we have learned so many things in our postgraduate days. Now we need to unlearn what we have learned because of in the light of the current evidences. So we need to see that what kind of fluid is important and which type of the fluid is important. That is, that is the key of this presentation. So thank you very much from my side. Khuda Hafiz.